morning or afternoon, everybody in the room and online. It's great to be with you wherever you are today. I feel unclear who I'm talking to, but welcome to everybody. I'm Lucy Gilson, the head of the Health Policy and Systems Division, and really pleased to welcome some friends from Kenya today. And we also had a chance to meet with a wider team yesterday, which was great. And really good to be gathering together and hearing about your research. And today we're really pleased that Dorothy and Michuki are going to present some of the work that we heard a little bit about yesterday, but we're looking forward to hearing more. As ever, there'll be a presentation and then time at the end for some discussion. And it looks like Michuki's going to go first. So welcome, Michuki, and over to you. Thank you.
Thank you, Lucy. Morning, afternoon, everyone. So my name is Michuki. I'm from Kenya. My background is in pediatrics and public health, and I'll take you through some of the work we're doing in Kenya and a project we fondly refer to as HiQ, which is learning to harness innovations in global health for quality care. So just to give us an idea, when you ask us from a newborn perspective, and because most of our work is in newborns facilities, and there are some assumptions that have always been held in newborn care. And one is that really the reason we have poor quality care is because we don't have technology, and therefore the assumption is that, look, if you improve and introduce technologies, that the quality of care is going to improve and the safety thereof is going to improve. But the other assumption we've always made is that when you improve this technology or any other innovation, whether it be a checklist or a new learning module, is that it will actually make things easier for the healthcare provider, and perhaps by making things easier, free up their time to do other more technical tasks. And that anytime you introduce a technology or any intervention, that the people on the ground, that's the healthcare workers or whoever is supposed to use that innovation or intervention, they have their numbers are adequate and they are really well skilled to handle that intervention. And so what we're doing is asking ourselves, do these assumptions hold true? And so one of the key components of care is nursing care, and we appreciate in most of our facilities, which perhaps might be the same in South Africa, is that nurses have a lot of work to do and have many competing interests. Over and above providing care, they also have other tasks that they are supposed to perform. And some of them are really not core nursing skills. For example, think about, from a finance perspective, having to fill in patients' financial charge sheets, picking up samples from lab, or wheeling a patient to radiology, or just cleaning cups or incubators or any other device. And these tasks, over and above their core nursing duties, really take a lot of their time. And I'm sure it also makes them quite stressed when they do that. So part of that, thinking about nursing care and their competing priorities, is that a couple of our colleagues did some work looking at how much care is left undone or missed from care provided in neonatal units. And this was work done about maybe 3-4 years ago. And what was interesting is that the work was done in different units. Mission hospitals are faith-based organizations, the private sector and the public sector, as you're seeing on the chart on your screen. And the red, perhaps want you draw your attention to the red dots, which are the public hospitals. The y-axis is an index that was showing how the quality of the care that was being provided, with anything above 80% being good quality care. What you appreciate is most of the public hospitals are clustered to the extreme right on your screen. And what we appreciate is that they have high nurse to patient ratios of anything between 1 to 10, and to some units an outlier there of about 1 to 38, one nurse to 38 babies, compared to the private facilities where one nurse is taking maybe care of 2 babies. And what you appreciate is that there's a clear correlation between the quality of care that is provided compared to the nursing ratio, the nurse to patient ratios, as is shown in this screen. And the whole idea would be to, whatever we do to improve the quality by improving the index. And so on this background, public hospitals in Kenya, this was work done in really neonatal units around the capital city, Nairobi. But think about this, that most of our public facilities, one nurse is taking care of about maybe 15 to 30 babies in a shift. Now bring this to give you a bit of context. About 3.5 years ago, I think almost going to 4 years, was a big intervention called the Nest 360. Nest 360 was an intervention that introduced technologies into neonatal units in Kenya, Malawi, Nigeria, and Tanzania, and they are looking at several facets of neonatal care, including feeding, taking care of babies who have jaundice, taking care of babies who are having trouble breathing by providing diagnostic equipment. And so this equipment was introduced into neonatal units in those 4 countries against the background of what you've just seen on the previous slide of really one nurse taking care of several babies. And that's where our project comes in. And what we're really trying to understand is how technology and human resource interventions can really be designed successfully so that you can have good care, not inpatient level, but also thinking about this care beyond the inpatient, their hospital stay, post-discharge at home. So this work, the work we're doing is in 3 main facets. The first work package is really looking at the addressing the shortages in workforce and how we can be able to address that to really improve care. But the second part of that work is really trying to understand the perspectives and what the benefits this improvement of workforce in a background where technology has improved, what benefits it has to staff, but also to the families. We appreciate most of the work we do as healthcare practitioners. We really, when we think about quality of care, we really want that baby to get better, to thrive and survive. But sometimes we really miss out on a very key component of the perspectives of the families. And that's one of the areas we're really trying to look at. The second part of this work is looking at care after the babies leave the hospital and trying to think about how can we really make that care better. And what we are doing at this point is to try and see what innovation can work to really improve that link between the baby once they leave hospital and getting post-discharge care, appreciating that in a lot of our settings, the baby might not get care, might not come back for care in the facility where they were born. So trying to see how we can make things a bit better for those babies and their families to really access care at the point that is nearest to them. Just giving an example, for example, you have a baby whose clinic is maybe 3 weeks from today. They live maybe 30 or 40 kilometers far from the hospital, and we expect them to come into the hospital at 9 o'clock in the morning on a rainy day, really not thinking about what it really takes for a mother who lives maybe 2 or 3 hours away to get them into hospital at 9 a.m. to see a doctor. So trying to ask ourselves, how can we really design post-discharge service that is really speaking to the needs of these patients and their families. So that's the second work package. The third work package is thinking about governance, and really when technologies are brought into facilities, who makes a decision that this device is fit for purpose, this device perhaps might not be safe in our population, and just trying to explore that space of how governance happens in our setting in terms of when technologies and new interventions are introduced. So we are privileged to have a large number of people and colleagues working on these work packages. But for the purpose of this discussion this morning, we'll just focus on the first section, looking at workforce shortages and the quality and the patient and family's perspective of that. So just to give you an idea of the workforce package, and the question we are trying to ask, if we increase neonatal staffing, are things going to improve? So our work is in about eight. So the next intervention is about 15 public hospitals in Kenya. And so what we're doing in our work is really focused on about 8 facilities, but in 4 of these facilities, our intervention is to really improve or increase the ward and ward staffing numbers. And what we're doing is that, as you can see in 4 hospitals, the first blue bar on your extreme left, that was at the beginning of the project, the intervention, which was about last year in March. And what we did is in 4 of these 8 hospitals, we had the opportunity to increase their nursing numbers, have 3 extra nurses in these units for to be there for about 1 year. And at the beginning of the intervention, we're able to assess care, and we'll talk about how we do that. And about 6 months into their introduction, we also went back and looked at how care is provided and trying to see is there a difference between the first and the second time period. But at the beginning of this year, there was also an addition of an extra cadre. Now what happens, as you remember, we said that there are several tasks that the nurse does, which are really not perhaps called nursing work. And the question we're asking ourselves is if we share these tasks with somebody, if the nurse can be able to share these tasks, these non-nursing tasks with somebody, does that free up the nurse's time to really do core nursing work? And so what we did in these same facilities, we added 4 extra ward assistants to be able to assist the nurse in nursing care. And where we are now is that what you're seeing, the red box. So we are at the point of doing another assessment to ask ourselves that those 3 time points have things changed, right? So that's what we're doing. So it's in these hospitals are public hospitals that I've mentioned. All are really level 2 hospitals, so they don't have critical care units, but they manage small and sick newborns. And most of the units are manned by medical officers and a consultant pediatrician, but they don't have specialist neonatologists. So what we're going to share today is how we do that care. And so we have part of our team members sitting in the unit for a shift which lasts about 12 hours. And what happened is about 3 years ago, part of our team, we were able to have some engagement with the key nursing stakeholders in Kenya. That's the professional association, the nursing, what's called, there's the regulatory associations and the professional associations, and to sit together and some nurse practitioners to ask ourselves, what would you say are the minimum standards that a baby is supposed to, the minimum standards of care that a baby is supposed to get based on certain categories. In terms of a very sick baby, these are the key things that we expect the baby to receive when they are receiving care. If a baby is perhaps maybe just finishing antibiotics on their way to be discharged, these are the key components that are supposed to be provided to that baby. And then based on those key components, we're able to develop a checklist where one of our observers, who is not a clinician, who is not a nurse, can be able to sit in the unit and against that checklist over a 12-hour period, maybe follow 3 or 4 babies in how the care is being provided in the unit, ticking whether a certain task was done or not done. And so they don't interfere with the care that is provided. They're just there as observers for a duration of time. And so they'll sit in, observe what the nurse is doing, and tick if a task was done, when it was done, who did it, whether it was not done, and maybe be able to comment. So the chart on your right is the kind of data that our clerks are able to fill. So what I'll share with you this afternoon is some of our findings. We are, as I mentioned, we are still doing, the project is still underway. And so what we'll be able to share with you this morning is some of our findings at the beginning of the intervention, what we found, where things were, and we are really hoping that at some point we'll be able to be more than glad to share what we found. So some of the results, again, we said this work is in 8 units, so we were able to observe about almost 240 shifts. These are 12-hour shifts across the 8 units, both day and night, appreciating sometimes, I'm sure you've seen reports that sometimes the quality of care can change between day and night and weekends. So we had teams sitting at different points randomly, either a weekend day or weekend night, weekday day, weekday night, to observe how care is provided. And we're able to observe about 900 babies across the 8 units and to see exactly what's happening. So on average, these units are extremely busy units with one nurse taking care of about 14 babies in a shift, in a 12-hour shift. And the number of babies a nurse has to take care of is much higher in the night, sometimes on average about 1 to 20 to 24, 25 babies. So you appreciate there's a significant change in the amount of work that the nurse who is coming at night has to do compared to. So you have more hands during the day compared to what you have in the night. And in this, what we're finding is that in a 12-hour shift, the nurse has about 32 minutes per baby. So that's 12 in a 12-hour shift. a baby will perhaps get only about 32 minutes of the nurse's time. And these 32 minutes are spread around several things that the nurse needs to do. They need to monitor this patient, this baby. If the baby needs to be fed, they need to be fed. Their babies are fed 3 hourly. So in a 12-hour shift, you expect the baby to have received around 4 feeds. If it's during the day, the nurse needs to attend ward round and hear what the conversations are, to be able to note down any new instructions. They're supposed to talk to the mothers. They're supposed to document. They're supposed to do a lot of infection prevention and control. And so this is assuming that in this 32 minutes, this is the only thing the nurse does. So we are not able to pick the time the nurse really went to the blood unit to pick a blood sample or our laboratory examination. So this 32 minutes is the time the nurse spent on the bedside. And the assumption is that all this nursing time was spent on direct nursing care. So you can see there that's a big challenge. And looking at how that time is distributed across the units, there are only one unit that had around a baby getting about an hour in the 12-hour shift. And these are some of the units that perhaps the patient loads were much less compared to other units. But in some units, you're seeing a nurse has around only about 25 minutes to take care of a baby. When you compare this to literature out there in the high resource setting, similar patient conditions where a baby gets around 5.5 hours of the 12-hour shift of nursing care. You can see what we appreciate is a big difference. And so the hypothesis is that by increasing staffing numbers, this nurse time provided is going to improve, and we are hoping to see what that happens. So just the question is, what happens? You have 32 minutes to take care of a baby. What do you do? So some of the things that we're finding is that the nurses actually start prioritizing who to give care. And so in the newborn unit, as you'll appreciate, there are babies with different conditions. And so what we've done is been able to categorize babies in 3 main categories, category A, B, and C, depending on the severity of the illness. So HDU patients would be in category A, and the stable patients who, for example, are in the unit just to maybe put on weight until the desired discharge weight, or is on a course of antibiotics for 7 days, or maybe the baby is on the 6th day of antibiotics. Those would be more stable babies who are category C. So what we appreciate is that in the limited, when we observe this care, the nursing care is actually prioritized to the sicker babies. So there's a form of prioritization as we see it. Now, this chart just shows one of the tasks that the nurse is supposed to do is attend clinical ward rounds. And you appreciate that in about a third of 30% of the times, the nurses attended ward rounds for the critically ill patients, the category A, compared to less than 10% of the times for the stable babies. But you appreciate even for the sick babies, almost a third of the time, the nurse is not present for the round because they are taking care of another baby. So what the first thing we appreciate is that there's some prioritization of care in terms of whose time the nurse will allocate their time to. The second thing is, again, in terms of assessment. So what happens, one of the tasks, as the nursing team hands over in the morning, there's what is called a pre-shift patient assessment, where the nurse is supposed to assess the patient themselves and make an objective assessment of how the baby is doing. Again, that is done more for the category A babies as compared to those who are in category C. So you can appreciate an issue of prioritization of care depending on how sick a baby is. The second thing is really what care is not done. This chart just is an indication of what are some of the tasks that are left undone. Like, for example, almost 65% of the times, linen was not changed during the shift, as were observed. Some key nursing interventions sometimes were missed, like, for example, measuring vital signs, pulse oximetry, and temperature. In about a third of the time, these tasks are not done as expected from the checklist. And sometimes even the administration of medication, oral or intravenous medication. So the question you ask is, if this care is not done, who does it? So what we're picking from our work is an informal task shifting within the newborn unit. And so this chart just shows some of the tasks that are actually missed by not left undone by the nurse, but actually done by the mother, rather informally. So in the first almost 80% of the times, the linen was actually changed by the mother and not the nurse. Also for cleaning the baby, top tailing, almost 100% of the times it was the mother who was doing this task. Never mind that these are supposed to be from the nursing curriculum, these are actually nursing tasks. The third one is cleaning the cord, which again was predominantly done by the mother. So what we appreciate is over and above prioritizing care, there is also an informal task shifting to the mothers, and the second group the second group to which the tasks are shifted to is the students. And so students, most of our facilities are training institutions, so we have students in going through the nursing curriculum, but you appreciate 80% of the times it's the students who actually take the vital signs. Again, administration of medication, again, about a third of the times, it's the students who do these tasks, and in a good proportion of the times, also unsupervised. Ideally, these tasks should be done under the supervision of the nurse, but the nurse is usually doing something else, and feeding the babies, almost for all the babies who have been fed by who needed to be fed, the nursing students were the ones who are doing those tasks. So what you appreciate is, again, informal task shifting to the mothers, 1, and 2, to the students, and sometimes these tasks are done when the students are not being supervised. So what does that mean in terms of quality of care? Again, we said babies in a 12-hour shift, we would expect the baby to be fed every 3 hours. And so that would be what around, in a 12-hour shift, you expect a baby to be fed around 4 times, okay? But what we have found is in about 65% of the times, there was incomplete, the documentation of feeding was done, really the baby fed about less than 3 times, okay? So that means the baby might have missed 1 feed. And so these are some of the implications that reduced staffing numbers have in terms of safety and quality of care. There is a reduced, some of the key interventions can be missed, for example, feeding. But one of the things we found that, because the person is there sitting, watching through the 12-hour shift and can be able to see when a task was done, some of the other challenges we saw is that at the end of the shift, the documentation is that a task was done, but because somebody was sitting there is able to appreciate that this task was actually not done for this particular patient. So you find the chart on your right is a documentation of babies having their temperature done when no temperature measurement was actually done. And you find, so in around a third of the patients, there were about 1 to 4 documentations that the temperature was actually taken, and indeed during the observation, because the team members are sitting there was no documentation, there was no observation of the intervention being done, like for example, the taking of vital signs. But in a good proportion of the times, when it's not done, in about 65%, it's not going to be documented, which is what you expect. But sometimes you see that a task is documented as done, but in essence, it was not done. So these are some of the challenges that we are trying to see, we have actually seen as an effect of having low numbers of staff. So this work is still in progress. We are hoping to see how this changes as we increase the human resource by increasing nurses and also by increasing ward assistants. So in summary, what we are saying is that the key issues that are emerging is that workloads are extreme in our context. We have some coping mechanisms that are coming rather informally, like shifting tasks and care, prioritization of care, either to the nursing students or to the mothers. But I think at the beginning of this project, what we are seeing, it's really not possible to use and adopt technologies in a setting where ward staff shortages are present. And I've been happy to share some of the documentation in terms of the use of the technologies and what we're actually seeing. For example, a baby on CPAP is supposed to be monitored every 3 hours, and a lot of the times that monitoring is not done because the nurse is actually busy doing something else. And so really challenges with adopting these technologies in a setting where staff shortages exist. But again, and a critical concern is issues of quality and safety, missing feeds or missing key interventions, or key interventions being documented as done and they are not done. So these are some of the things we are seeing. we'll see how that shifts with time. And I'm happy to introduce my colleague Dorothy to come and take us through some of the experiences of the staff members and their families. Thank you very much.
Thanks, Michuki. So what I'll do in the next couple of minutes is take you through the qualitative arm of this study, which quite complements the quantitative work that Michuki has just talked about. So as Michuki has highlighted, the newborn environment is quite a stressful setting, not just for the staff working within the newborn unit, but also for the mothers. From literature, bottlenecks have been documented, so ranging from high workloads, understaffing, which could potentially have an impact on the experiences of both the nursing staff as well as the mothers within the newborn unit. For the nurses, this has been shown to contribute to issues to do with burnout. And if there's high workload and the nurses don't have time to attend to the mothers, could also contribute to the ability to provide support to the mothers within the newborn unit. And therefore, it's important to start exploring and to understand how interventions such as the technologies and the staffing intervention that we've introduced within these 4 newborn units can help to alleviate some of the problems or the challenges experienced by both the mothers and the staff, which is what the qualitative aspect of this study is interested in. So within the qualitative arm, we are interested in exploring how the workforce intervention and how the introduction of the technologies affect the experiences of both the staff and the families. But within that, we also have a DPhil student who's interested in looking at the role of technologies and how that shapes communication and decision making among health workers in the neonatal units. In terms of how we go about collecting this qualitative work, we use an ethnographic approach where we conduct non-participant observation, appreciating that many of our colleagues collecting this qualitative data are not medically trained, they're social scientists. And we conduct extended hours of observations within the newborn unit, so covering different days and also different shifts. We also spend a lot of time talking to people within the newborn unit, approaching that through informal conversations, but also having more structured, in-depth interviews and narrative interviews with the mothers. Our study population is mainly the mothers and the nurses working in the newborn units. And so far, we've had different cycles of data collection rounds. So we start just like the qualitative aspect. We started with the baseline, just going in before the introduction of this of the interventions, just to understand what was happening at that point. And then after the introduction of the nurses, we went back for another round of data collection. And currently, we're in the final round of data collection after the introduction of the ward assistants. And these are some of the key areas that we are interested in with the ethnographic work, basically understanding the context, because the context in which the interventions are introduced is very important, because they shape not just the uptake, but how things pan out over time. We are interested also in the practices and the processes of care and the relationships within that space, including aspects to do with communication and the challenges of the mothers and the nurses working in that setting. I'll take you through some of the preliminary findings from the qualitative arm. As I've alluded to, in this kind of work, it's quite important to understand the context, because context really matters, because it shapes everything that happens. We don't introduce the staff or the technologies in place. And we have to appreciate that the 4 hospitals are very different. So we capture thick descriptions of how the setup, the staffing, the resources available, the processes in that space. So in this slide, I just give a snapshot of the key differences across the facilities. So you can see some are in rural, some are in urban settings, and also there's differences in the sizes of the newborn units. But of importance, which I've highlighted there, is Hospital 11 has got the highest number of babies, and that has implication for the staffing workload. But again, looking at the available resources, for example, the incubators, what we are seeing is babies sharing incubators and cots in those facilities. And again, that has implication for things to do like infections and IPC within those facilities. In this slide, I just give us a snapshot of the shifts and linking back to the number of admissions per hospital. So just to emphasize again, what Michuki had introduced is what we are seeing is fewer nurses as opposed to the number of babies they're caring for during the night shift, which is a real challenge. And mothers are also concerned about that, because during the day you have got these other cadres of staff present in the wards, but at night many a times it's just the nurses on those in those settings, and mothers are able to pick those differences and to voice some of the concerns that they have being left alone at night with the sick babies. All right. So as part of the ethnographic work, what we also do is develop sketches just to map out how the spaces look like, how they're organized. And this is quite important because for this slide, I'll take an example of where the KMC room is located versus where the nurse's table is at. So this is the KMC is an enclosed room, which is just behind the nurse's station. But what we are seeing is many times mothers not being comfortable because a lot of attention is given either to the premature baby's room or this other room with the acute babies due to the task prioritization that Michuki had highlighted earlier. So many a times, some of the mothers use words such as, I feel like I'm in a prison when I'm in the KMC room because they're on their own in that space. So it's quite, what I'm driving at, it's quite important to take into consideration the layout of the neonatal unit and how that impacts on the processes, support structures, and mothers' experiences within the newborn units. In Hospital 11, it's relatively bigger than the previous one, but again, driving on processes and also the size of the room. So you can see the nurses' station, where the nurses spend most of the time is here, and then you have the entrance to the NU on that end. So for IPC, in terms of monitoring what's happening, if the nurse is sat here and her attention is drawn to this room, she will not be able to look at whether mothers are putting on their gowns, control the number of visitors coming into the newborn unit. That has implication for infection prevention control. Just to give an example. So what I'm driving at with this layout and these pictures is that layout is very important when we're looking at aspects of quality of care. Right. So I'll move on to some of the similarities across the hospitals. So differences based on resources, which is also quite important. So in 3 of the hospitals, looking at availability of bed linen, these are provided in 3 hospitals, but not available in Hospital 11. What that means is mothers come in with their kangas and their shawls, which they use in the courts. Again, having an implication on IPC within that facility. When it comes to availability of supplies, we have a shortage. We've observed a shortage of gloves across all facilities. Then you start asking yourself, what does that mean in terms of safety and ability of the staff to effectively offer care within those settings? And in Hospital 2 and 6, we are seeing instances where mothers have to buy drugs or even seek tests like such as bilirubin tests, which are not available within those facilities. And what that means is that the mothers have to incur out-of-pocket expenses. Again, the challenges with availability of hand washing, soap and sanitizers in 3 out of the 4 hospitals. So in terms of similarities and differences based on communication, orientation is quite key within the newborn settings. But in 3 out of 4 of the hospitals, there's some form of orientation. Actually, in 3 out of 4, in 2 that the mothers are not orientated when they come into the newborn unit, so they don't know what to expect. Task sharing is a norm that's happening. But if I don't know what I'm supposed to do, where things are, then how do you expect me to comfortably take on those roles? But in hospital 6 and 4, there's some aspect of assistance with coming from the nursing students and also some other cadre of staff orienting the mothers in the newborn unit. Across all hospitals, what we are observing is a practice of exclusive breastfeeding and also formula milk being provided, and some element of support, which also varies across the facilities. So this is a really key issue when it comes to feeding of the babies. And as you can see from the quantitative data, feeding is one of the tasks that has primarily been taken on by the mothers. So if there's no support for them to take on these tasks, then that's a real problem when it comes to quality and safety issues as well. So in summary, we are seeing there are common conditions for the babies across the 4 facilities. There's the absence of the nurses during the major ward rounds, mainly because of the prioritization of tasks. There are challenges with gloves and other supplies across all the 4 facilities. And because of the prioritization of tasks, we're seeing a lot of informal peer-to-peer support happening within the newborn unit, where more expert mothers are supporting the novice or the new mothers within the newborn unit. And differences in times of the nurses per shift. And as I've said, mothers are also struggling with feeding of the babies, and also some of the technologies limiting their ability to interact or to bond more effectively with the babies. In terms of the differences, the layouts in the facilities are quite different as I've shown in the previous slides. There's free formula milk provided in 2 of the 4 hospitals. There are scheduled ward rounds in 2 of the 4 hospitals, and KMC is continuous in Hospital 11. And Hospital 4 is the only one with a nutritionist who supports mothers with feeding and breastfeeding of attachment. We're also seeing differences in terms of communication with mothers during emergencies in Hospital 11 and 12. And that could be linked to the issue of the number of the babies that the 2 hospitals are receiving and the number of staff available. As I indicated, we had a second round of data collection after the introduction of the nursing staff, and I'll just give a snapshot of what is coming out from the qualitative study. So what we are seeing is the introduction of the additional workforce having some positive impact on the staff well-being, in that across all the 4 facilities, they had accrued number of leave days. So when the new nurses came in, the existing or the old nurses were now able to take their leave days, and they also appreciate the fact that they now have extra pair of hands, and they appreciate the task sharing happening within those spaces. But despite that, talking to the mothers and observing the interaction between the staff and the mothers, what we observe is no marked changes in terms of the interaction with the mothers. In many of the facilities, the number of times the nurses are joining the ward rounds has not significantly changed. So therefore, the question moving forward is still asking, why aren't we seeing a considerable change when it comes to joining ward rounds and the nurse-mother interaction? So could this be a norm? Could there be structural issues that may be contributing to that, just apart from the introduction of staff that we need to take into consideration? All right, so I'll briefly talk about the second question, which is being addressed by the DPhil student in terms of how communication happens, is shaped by technology. Just to give a background, you know that technology can help decrease neonatal mortality, but we're introducing the technologies in a complex health system, and it's therefore important to appreciate that, and also that from the literature that technology affects communication between the staff working in the newborn unit. And as Michuki has said, NEST introduced a bundle of technologies, but the student looking at this aspect of work has mainly focused on communication around two machines, that's phototherapy and the CPAP machine. So preliminary findings from her work has illustrated different types of communications happening within those spaces and linked to the two technologies. So she's classified them into two. So the first one is instruction without discussion. So as you can see by the quote there, it's like the more senior doctor shouting and talking down to the junior intern MOs while passing information about technology use. The second one is listening passively. So from that quote is like, so the doctors are the ones who will come with the results. Then they see whether it is below the threshold to continue or supposed to be win. So this means that communication is one directional, just coming from the doctor, and the nurse just does what the doctor has prescribed. And then there's assertive, where there's a bit of information sharing and discussion between the different cadres, and the two, either the doctor or the nurse, being in agreement with the decision that has been made. And then there's resentment passive, where one cadre does not agree with what has been prescribed by somebody who is in a higher cadre, but do not voice that out as compared to the aggressive form of communication. So these are the four main types of communication styles that are happening around the newborn unit based on the communication. So just in summary, in terms of what's affecting and what's leading to the four types of communication, one is the workload. And again, issues to do with staff rotation. So if students are only staying within the newborn unit for a limited period of time, that has implication on the experience and their confidence to use the technology, but also the staff attitude, which links back to the issue of intercadre relationships and power dynamics. So these are the key issues that are affecting how staff are communicating with each other around technology use within the newborn unit. So apart from the HiQ, I think it's important just to point out that we also have two other studies linked to HiQ that we've been conducting. So the first one is the RESPECT study, which is basically exploring the experiences of mothers of preterm babies and using that to co-design interventions. So far we've worked closely with colleagues who are working in our nurses communication training. And moving forward, we are in the process of setting up another study that is interested in identifying vulnerabilities, mothers' vulnerabilities, and documenting that up to 6 weeks post-discharge with a view of coming up with a tool to assess those vulnerabilities and in the future inform strategies to address some of the childbirth-induced vulnerabilities. So as I conclude, I'll just leave you with a snapshot of some of the key issues emerging from the other aspect of the qualitative studies. So using real-life examples of what mothers are saying about experiences experiences within the newborn unit. So this particular mother raises a key important issue of the importance of lack of communication, being provided with adequate and timely communication, because it's because of the lack of communication that further makes the worries and concerns much more wide in the newborn unit. So she's saying, nobody sat me down to tell me, don't panic, don't worry. So the lack of being provided with some support and some form of comfort. And she goes on to say, there was nothing. So it's all just your mind working overtime. And for quality of care, then you just start thinking about, if she's anxious, will she be able to produce milk for the baby? Will she be able to bond effectively with the baby? So we're learning a lot from the narratives, which can inform our quality improvement strategies. And in this second mother is talking about lack of connection with her baby. So because of the fears about the outcome of the baby, they worry a lot about their babies dying, because they see very many babies dying within the newborn unit. So as a coping strategy, what we are seeing is many of them detach from the baby as a mental coping strategy that they employ, which is something that can be addressed with better support. So listening to the mother's voices, we're able now to start thinking about what additional things can we do to support the mothers within those spaces, apart from the workforce intervention and technology, just emphasizing that some of these soft issues are really important within that space, and we need to address those as well. Thank you.
Thank you very much. Thanks very much I'm just going to see if I can find the people online. Here we go. Thanks very much to you both for absolutely fascinating presentations, and just really great to see such detailed health systems research addressing such important issues. So there's colleagues online and there's colleagues in the room. If you're online and you want to raise a question, please, I'm looking at the board of people, so raise your hand. And if you're in the room and you'd like to raise a question, raise your hand. Let me just give you all 30 seconds to think about questions. Great. Tumela, I'm going to ask you to go first.
Thank you very much. Thank you for a very nice presentation of a very beautiful project. So I just want to know, from what you've seen so far in the project, or from the study, have you observed any clinical or improved clinical outcomes for the babies, especially those who are very sick? Number two, it's quite common to have nurses do other things when you supplement them with more staff. Managers or supervisors would make them do other things. So is that what you observe as well in the units? And what about support supervision given to these nurses? Was there sufficient support supervision that was given or not? And was that one of the things that contributed to the distress that you see among nurses?
Great, so there's 3 questions there, and over to you guys to respond. And again, just if anybody wants to online, put it in the chat box and I'll check for you.
Correct.
Michuki or Dorothy, yeah.
Thanks. So thank you. These hospitals are part of a network where we're able to monitor the quality of care through the time the baby is in the hospital, and so that's still data we are looking at. But of course, I'm sure you agree, it's very hard to tease out that the quality has improved because of just one intervention. There are many other things that happen in a ward unit, and it would be quite difficult to say that really perhaps things like mortality is improving because of these interventions, but we're still looking at that data. The second was about supervision or task whether people given other tasks. So part of the work that we're doing is a time in motion study where we actually literally shadow this nurse through her 12-hour shift to see over and above seeing what the care that they are providing to the baby, what other tasks do they do during the 12-hour shift. So that's part of the work we are still doing, and to try and see in this 12-hour shift, the nurse had to go in for a meeting that took 45 minutes, had to go in to represent maybe the head of the unit in a procurement committee meeting, all those kind of things. So that's data we are looking at to try and ask ourselves, over and above these 32 minutes in the 12-hour shift, what are the tasks is the nurse actually carrying out? So that's the information we're also quite interested to see how that comes out. The third question was about supportive supervision. Well, that's happening because most of these facilities, what happens is most of these facilities, over and above being training institutions, still have faculty members from the training institutions coming in to support, especially the students. Sometimes they come, sometimes that support is, I'm talking about now supervision for the students. That support is supposed to be offered by the resident nurses, who you're seeing have just about 32 minutes to take care of the baby. So that's some of the things we are seeing in terms. I agree with you. Some of the questions we want to ask is this 30, over and above these 32 minutes, or these are the time, what is it being spent doing? And perhaps it might just be maybe supporting the students, and this is information will be.
And support for the nurses?
Support for the nurses, I leave that to the group, not much. We don't see much of it, at least not in the public sector, because sometimes you're the head of the unit is part of the team really working very hard, the person who is supposed to be doing the supportive supervision. So with the limited staff numbers, sometimes we find at all hands to be really all hands on deck, so not much. Yes, Cecil?
Well, no, I was just thinking one of the pieces of information that you shared was that when the extra nurses were brought in, immediately some of the nurses that were there already went on leave, which actually is a really important thing in terms of people getting a proper break. But that's an illustration of how if you bring in extra nurses, it doesn't necessarily mean you've got immediately, an additional 3 people in each facility providing that care. So I wondered if that was partly what you were also getting at.
Yeah.
Yes. I mean, you also raised in your points, Dorothy, that the sort of relationship within the newborn units is not great necessarily between people. So the level of support they're offering each other is not great.
Yeah.
Do you want to respond too? I've seen your hand. Thanks, Michuki. I think we can sit still. If you can't hear online, shout.
Yeah.
I think we can sit still.
Yeah.
Please, Dorothy.
Yeah, and also a contextual issue that it's important to take into consideration is the leadership styles within the new community, because what some of the data are showing is the differences in how the nurse managers across the 4 hospitals are running the hospitals could also be playing a role in what is happening within the new community. So, from one department to another is we're going to take longer breaks, which is something that we were seeing in some happening in some of the hospitals. So context and the norms and the culture within the new community is something that's also quite.
I find it quite fascinating the ways in which the hardware interventions can make a difference, but then you've got all that software stuff that may counter them. Maina.
So thank you so much for those presentations. The thing that kind of worries me a little bit in terms of either formalizing or informalizing the care that the mothers and caregivers bring to the baby. I think there's so many layers involved. Then we must hear if you are doing any detailed work with a mom. So if a baby is very sick, they could be in that neonatal ICU for weeks. And so does it eventually then with the task sharing become an assumption that the mom will be available to do those tasks that the nurses aren't able to do for the baby on a 24-hour basis for weeks? And what does that mean for the mom or caregiver when they have other children at home and where they might be staying 2 or 3 hours away from the hospital? So I'm just kind of, I don't really know what the answer is, but how does one actually very importantly, involve mothers and caregivers in the care team, but without placing an undue burden on them in the sense that they then feel if I'm not there, my baby isn't going to be cared for, and therefore I'm obliged to be there, and therefore I have to forego some of the other, important aspects of life, such as caring for other children at home, or what about work for those moms, etc., etc. So.
And what about the costs of all that as well?
Yeah,
The
yeah.
lost economic, lost earnings perhaps, as well as costs on the household. Michuki. Or Dorothy today.
Yeah, so unfortunately, because of time, I wasn't able to project other findings related to that. So that aspect of being detached from your life at home, the impact of the hospitalization on the economic well-being and the earnings. So that is very critical, and it is quite, it's coming out quite strongly from our interactions and the discussions with the mothers. And just because of the way the public system works in Kenya, the mothers are required, obliged, to be in hospital for the entire time that the baby is unwell. The only day when the baby is okay to go home. So all these things have implication on all those aspects that you're raising. So this is something that we are definitely seeing. Loss of income, detachment from home, worrying about loss of jobs. So these are issues that are coming on from the mother's narratives in terms across all the hospitals. Yeah.
I mean, so there's a big picture question here of how the research that you're doing might possibly inform some changes to address the situation that is basically putting burden on mothers as well as on nurses. So can you tell us briefly, as we wrap up, how you hope the research might contribute to changes, knowing that that's difficult?
All right. So we work quite closely with mother support groups, and I think that's an area that we are likely to explore further. Apart from just conducting research and contributing to advocacy at the government level, policy level, that these are issues that need to be addressed. Yeah. For example, maternity leave. This is something that needs to be looked into, providing better psychosocial support for the mental well-being of the mothers and advocating for that. And also bringing the mothers through the mother support group to this discussion at the table, and give the space for that moving forward.
Michuki, anything you want
Yeah,
to add?
and maybe the question is, adding 3 nurses, is it enough? That's the question. Some of the things we need to ask ourselves, but also part of the work we are doing is trying to do, there's a costing element to it, because the policymakers and the governments need to know how much does this cost. If you want to, this is the cost to add an extra 1 person in the unit, and this is the change they're going to bring. So those are some of the questions that we are hoping to be able to address, and hopefully provide information that can be used to see how many people need to be in the unit for the missed care to significantly reduce here.
Right, Sassy.
I'm just, in addition to that, I think it's maybe important for everyone to be aware that there's stakeholder engagement, including of policymakers and senior practitioners and professional organisations right throughout this work. So trying to get the data back, making sure it's available. And so it's not just advocacy at the end, but involvement of those stakeholders throughout. So hoping that when the opportunities come to make changes based on some of this learning, there's an opportunity to implement it.
Great. Well, thank you very much, everybody. Really, thank you so much. Very rich presentations. One of the problems in South Africa is something called medical legal claims. So provinces have huge budget overhangs because of claims by parents, mothers, about children quite often, and poor quality of care. And I was wondering, through the whole thing, through your whole presentation, now, what actually goes on in our health facilities, and how much of the same sort of phenomena are experienced, and actually then also contributing to these incredible, obviously difficult situations, but that have consequences in terms of budget overhang, which would prevent employing new staff. So we've got lots to learn. Thank you very much indeed. Thank you to you online, and see you again next week for the noon meeting. And we're so grateful to have had our colleagues from Kenya visiting us. Thank you. Bye-bye, everybody.